So we were talking about global access to otology, how to use telemedicine to improve the options to the population in the world, especially poor communities. So I was talking about how during the previous years, exchange of products and services through digital platforms has increasingly grown during the last couple of decades. So in fact, nowadays, some activities cannot be done in a different way. The practice of medicine through digital channels has not been one of these leading sectors. This pandemic has exposed deep vulnerabilities in healthcare systems, supply chains, and social structures, and basic inequities that need to be addressed. As societies emerge from the crisis, we can aspire to do more than simply return to normality. With COVID, we are discovering that there are a lot of things we can do virtually that we never thought we could. If we look to our medical field, otolaryngology, it is evident that this is a scarce resource, especially where are most needed, rural areas and developed countries and poor community. But even rich people can struggle to find a good care for their senses in some places distant from big cities, which can be visited during holidays, trips, or the practice of some sports and adventures. So in my opinion, this is a global world with a non-global medicine. In my opinion, medicine is not taking advantage of the current communication resources. So this is a wonderful opportunity to change that. So remember that today's innovation are the intervention of tomorrow. So it's pretty easy that now it's very common to see homes equipped with elements at blood pressure cuffs, thermometers, and a variety of other medical instruments. This is the case a couple of weeks ago. Sometimes a patient asked me about how to use medical devices solid over the counter in a pharmacy or in a store or the internet through Amazon that I simply don't know. The price of some specific ENT exclusive requirements like video otoscope or audiometers is decreasing, and common customers are showing bigger interest in buying them. So besides that, if we compare ENT practice with other specialties like, for instance, radiology, cardiology, or robotic in general surgery, we will see that we are behind. I still remember 6 years ago, I was at the OR trying the new Da Vinci robotic surgery, and I saw a surgeon from Brussels in Belgium just doing esophagus surgery here in Bogota through robotics. So it's very nice. And I think ENT is back behind. So, but to be honest, there is another big motivation to explore technological interactions among people, my kids. Since they're living in the other side of the planet, I have been forced to expand my communication skills using internet to accomplish my task as a father. And please, I'm not saying that virtual contact with my kids could replace and even together at home, making a dinner, for instance. But first, there is no option. And at second, it brings some advantage. But I will talk about this later. How's the sound? Is okay, Richard?
We're good, Martin. Thank you.
Okay, excellent. So the idea of this lecture is to show you that a good remote medical care, especially in otology, it's possible, and the most vulnerable people in the world will be the most benefit from this initiative. Based on our experience during the last 6 years doing teleotolaryngology in our center, the Centro Los Sentidos, based in Bogota, Colombia, I would like to expose the myths that, in my opinion, have reduced the expansion or the speed of the expansion of virtual ENT during the last decade, and the facts about this critical perspective of detractors. I shall begin saying that I really believe that we as physicians can use technology not to replace, but to expand our connection with patients. So let's talk about these myths. The myth number one is, in most cases, it is not possible to do a trustworthy ENT evaluation due to the anatomy and difficult access to the organs that we see. So the fact is, most of the families in the current world, in almost every continent, have access to a smartphones and internet. We think that with the right instruction to the patients or relatives, we can do a nice physical examination, useful enough to make a correct diagnosis when it's correlated with a comprehensive medical history. And I would like to remark this point. Remote healthcare requires a higher level of skills in communication, questioning, listening, and especially observing. We found that a good self-physical examination tutorial is the best way to train the patient. So we sent, previous to the appointment, to the virtual appointment, we sent a video training the patient and relatives to do the self-physical examination. The crucial factor in this, in the success is the light. So in most cases, the flashlight from a cellular phone is enough, and in some cases, a lantern could be useful. We found that getting ready a pre-recorded video following the tutorial would give us better quality images than a real-time video because the variable speed of the internet, especially in remote areas. Remember that we are talking about poor communities and rural areas. So these are some pictures from real patients. All of them were taken with cellular phones, with the cameras. We asked the patient or relatives to touch the neck and looking for masses or palp any kind of nodes or bulbs and feel pain in the neck. We ask the patient to open the mouth and feel the temporomandibular joint, looking for pain, and take a video of the throat using just a fork or something flat. It's useful to decrease the tongue. We ask at the same time the patient to pull out a little bit the nostrils in order to see into the nose, the nasal septum, turbinates, rhinorrhea, etc. And then we ask to film, to record a short video from the eye, and we look for pupils diameter, for nystagmus, and in these cases, we ask the patient to do a SQ test, which helped me a lot in order to rule out posterior fossa issues. I even train relatives to do positional tests in order to look for nystagmus in these cases, and it works pretty well. Of course, we look for the ear. We ask the patient to use a small cone to direct the light of the cellular phone into the ear, and it's usually enough to see the external auditory canal and the light come from the tympanic drum. We see the face of the patients, looking for facial nerve issues, and usually the physical examination it's enough to have a good idea of the situation of the patient and correlated with the medical history. The myth two is our diagnosis is based very frequently in procedures that require sophisticated equipment available only in our clinics. For instance, microscope, flexible laryngoscopes, audiometers, etc. So the fact is that every day are new technology resources, devices, apps, and gadgets that allow us to perform in a good way a remote medical evaluation. I just want to show you the two only devices that we currently use in our practice. And these are available for the patient as a part of a kit that we send them annually we send it to the patients affiliated to our annual membership. We have a group of patients that belong to a membership, and they receive a kit with this equipment. So they can use it for themselves or for their families in every appointment. But if this is not the case, we use homemade elements and apps. So we use this device. We bought it through internet, $12, $12 US is the cost. It's a very small device, like an auto-endoscope, that the person connects to the cellular phone or the PC or laptop. And you can see the images, real images from the patient, from the ear, which is very good. And actually, he or she clean it and use it into the nose and into the throat. With good images, and the quality is fine. Enough to do a diagnosis. The other gadget that we use is an audiometer. And the idea is that one of our audiologists, who is on the screen, is making an audiogram through internet using an app that we design. And the precision is very nice. We calibrate the equipment with 3 different earphones, Apple, Samsung, and Bose. And when we compare the calibration with our equipment at the office, the difference is between 5 and 10 dB, which is, in my opinion, pretty nice. And even we can use the vibration device or the phone to do a Weber test. It is absolutely clear that the precision of this device is not as good as in our offices, but at least from our experience is good enough to resolve the patient's complaint. So the myth number 3, it's otolaryngology is a specialty that requires in big proportion in-office therapeutic procedures and surgeries that cannot be done remotely. Definitely, not every patient can be treated remotely, definitely. So selection is absolutely crucial. In order to fulfill expectations for patients and physicians, the e-triage is really important. Some cases, for instance, foreign body, we're talking about ENT, not just otology, like epistaxis or the stridor, should be referred to physical care. We not offer this kind of service to these symptoms. However, if we take a look to the statistics and global tendency on health, it is evident that in the immediate future, the vast majority of otology cases can be addressed online. I would like to show you this slide with a recent study from the Institute for Health Metrics and Evaluation about global burden of disease that projects an epidemiology shift in the upcoming years. This is 20 years, from 2020 to 2040. In mature economies, population is aging and faces lifestyle health conditions as diabetes, cardiovascular disease, and cancer. But at the same time, there is a greater health gain in low-income countries, mainly from preventable and treatable causes, such as infection, nutrition, and maternal health. That means, for example, that we will see in our practice a larger number of chronic respiratory disease, vision and hearing loss, dizziness, migraine, and communicative disorders, and a lesser numbers of ear infection and tympanic perforations, for instance. In the black spheres are infection disease, and you can see how we expect a decrease in the number of cases during the next 20 years. In the opposite side, there will be a lot of diseases related with the lifestyle of people. So I think if we have conscious of this change, of this big shift, we can use technology. For instance, we have designed and incorporated in our platforms apps in tinnitus, vertigo, voice disorders that improve our therapist rehabilitation protocols and have excellent patient adherence. But if we look beyond, and I would like to to quote Loy Minor, our colleague Loy Minor. Loy Minor is the current dean of the medical school in Stanford, who makes a difference between sick care and health care. If we expand the classical scope of our practice as otologists, getting out of the boundaries of a tertiary or quaternary medical facility, we could look beyond the supra-specialized and very expensive healthcare treatment for the sick and look also at the social, behavioral, and environmental determinants for health. So in my opinion, remote healthcare can help to predict and to prevent the disease in a more efficient way. So the myth number 4, it's patient dislike this impersonal experience. Well, the fact is, we asked about this 6 years ago when we started with our program in telemedicine, but there has been a big shift in public perception of telehealth care. In a survey in February 2020, 48% of respondents, this is from Johns Hopkins, 50 years of age and older, who we suppose are more reluctant to use internet, who has never used telemedicine, say they will be likely to seek virtual channel of care in addition to or in place of physical visits. I'm pretty sure these figures will be much higher after pandemic. I would like to point as well that it will be naive to ignore the great economical pressure in contemporary medicine. The big new healthcare stakeholders, because it's, except the public systems, private healthcare is the larger proportion of healthcare in the world. Many of these stakeholders are coming from the technology and media business, and they are pushing for automation, boost quality of care, and decrease spending, which open the door for broader strategic investment in virtual health. So besides the financial aspect and how this will boost the change in telemedicine, I would like to talk about the nice things about telehealth, because it comes with some real advantage that explain why 80% of patients who has used telemedicine will recommend it. Let's talk about some advantage. First, video visits technology can facilitate the provision of a specialty level to patients for whom getting to a clinic is difficult due to functional limitations, for instance, handicapped patients or geographical distance, which is a real advantage in my country, for instance. Video visits may supplement in-person visits by providing continuity and follow-up easily. Telehealth can address urgent concerns more rapidly, which is a real advantage. I'm very appreciative for people and families. Video visits may add value by allowing clinicians to see into patients' home environments and meet loved ones, such children, pets, who may not normally appear at an office visits and play a role in the health of a patient. Video visits allow the physician to assess the patient's social situation. And it's very interesting to, when you ask to the patient to walk with the camera just to see the posture, etc. If you take a look to the background, you will have a good idea of the social environment. Video visits offer the opportunity for remote family members to participate in the decisions, which is absolutely crucial in the success of some treatments like surgeries or cancer treatments. Vulnerable population around the globe has the opportunity to benefit greatly from the teleotology care for the very first time. I'm pretty sure, and I have experience from people in some rural areas in Colombia, South America, and Africa, that they have for the very first time contact with an otologist, because it's not an available resources in all the countries. So this is a real great advantage. Video visits offer a comfortable setting for a person with illness, thereby increasing the quality of communication and trust between patient and doctors. So the relationship used to be very more comfortable. And finally, probably the most important thing is that it works. In our experience during the last 6 months, we have done a survey. Just 70% of them were sent to a physical visit. In my opinion, the key is the case selection. So there is a myth number 5. Richard, are you there? It's okay to sound?
Everything's good, Martin. Thank you.
Okay, excellent. So the myth number 5 is legal risks are too high. So the fact is that, of course, informed consents are mandatory. But beyond that, and again, selection is crucial, and it is really essential to establish with the patient the scope and objectives of the consultation. So I would like to share with you this classification of telehealth, which is, in my opinion, the simplest, and divides in 3 core categories. The first one is telehealth, with 3 subcategories: the real telemedicine, synchronous, live, two-way audiovisual interaction with patient and providers, which is 90% of our practice of telehealth. The second subcategory is the asynchronous. I'm talking about how you can see an MRI, an X-ray, or lab test through the internet. And there is a remote patient monitoring. For instance, insulin pumps are this kind of examples where we just collect personal health or medical data. That's it. The second category is the digital therapeutics. It's very useful for pharmaceuticals, talking about replacement therapies and treatment optimization. And the third category is care navigation. And here I'm talking about two groups. First, the patient self-direct care. I mean, you manage your own information through website, for instance. And the e-triage, which provides support and searching for and schedule appropriate care based on symptoms, condition, etc. So, as in every medical and human act, communication skills are vital. And we are talking about legal risk and how to get a happy patient with experience. Simple things like call the patient by her or his name, assuring patient comfort, and identify the real complaint of the patient are very useful to connect. I would say essential to connect patient and physician. In particular, when in a virtual encounter, it is important to pay attention to patient's environment. But in general, patients are more comfortable, secure, relaxed at their places than in a clinic. So in our experience, it's a more relaxing experience. Another important aspect, of course, is to know all the legal considerations which are different in every country. I just can say something about Colombia, but of course it's pretty important, and everyone has a good idea about how the legal aspects in every country. So the myth number 6 is this kind of practice is boring and time consuming. And the fact is that we spend almost the same time in a virtual appointment than a physical appointment. And even with the pre-recorded physical examination could be even less. And it's a tremendous saving of time for patients and families, not to mention the reduction in cost for patients and doctors. Could, by the way, can see the patient from everywhere, which is a very interesting aspect of our practice because it gives us freedom as a physician, which is a pretty good advantage. So I just want to say that it's very important to remember our mission. This is a perfect time to change to improve our practice, and it is an incredible opportunity to contribute for a fairer healthcare and perhaps close the gap between poor and rich societies. I didn't like the world before the pandemic. I had the wonderful opportunity to be trained in some of the best universities and facilities in the world, and I live in a country where the geography and socio-economical barriers make impossible or almost impossible for the majorities to have access to subspecialty medical care. We, the physicians, as the people privileged to custody the wellness of our communities, can use technology to take care of our routine work and our technical task, allowing us more time to deliver a more comprehensive attention to our patients. So we can do it. We can do it. The world is changing, must change, and medicine must change as well. We can help people in the newest, more accessible, fun, and efficient way. So that's it. That's what I wanted to talk to you today. So thank you.
Martin, can you, there we go. Martin, can we see you on your camera?
Let me see. It's completely black.
Okay.
Okay, I'm here.
All right. Listen, very interesting subject because, you know, as we say, in today's world with, the corona pandemic, it's changed the way that we have to deliver our healthcare. You know what was interesting on that one chart you showed with blue bubbles and black bubbles? They said that the incidence of infectious disease was going down, whereas cardiovascular was going up. I think perhaps the people that wrote that article need to reassess their opinions. Okay, that's just my first.
This is a prediction for the next 20 years.
Yeah, okay.
It's not now. It's a prediction.
All right. Listen, I think it would be really good for people to ask questions because I believe everybody who's in this lecture today, and we had up to 32 people, are doing some form of telemedicine. And I think the myths that you showed and you talked about are apropos to this whole world we live in. Maybe you could share with them, like, what platform are you using to test hearing online? Okay, what devices? Where can they get this device to look? To hook to the phone so that people can look at their ear. Maybe you can share that with us, and then anybody who has a question, please join in. Okay.
I guess I have the device, one of them at home. I can show you. I just found it through internet. Actually, it was a suggestion from our friend Ashkan Monfaret. Ashkan told me about this device. I looked through internet. It cost $12. I got it in just 5 days here in Bogota, Colombia. And now we had the opportunity to send to our patients previous to the appointment. So it's a good thing. I had no previous idea about this. It's not that FDA approved. It's over the counter. It's just to self-clean the ear. That's it. Okay. It's pretty simple, but the images is fine.
Maybe you can put a link on the platform on WhatsApp where people can see this device and maybe
sure.
Get access to it. What about the Otology program? What are you using for that?
Our audiologists, one of them, decided to prove some ideas, and now we have an app. It's under test in our platform. We can use the Starkey audiogram, which is very good. It's completely free of charge. Samsung has a good audiometer as well. It has a cost. And there are several options in English and Spanish, for sure in other language as well, completely free of charge. So the idea, what we do is ask to our audiologists to prove the audiograms, different kind of audiometers available online, and see which one is the best, is the most accurate device or app. But in our experience, we are we develop our own audiogram.
Okay, if you can send links to the Samsung and the Starkey.
Absolutely, I can do it to you.
Okay, all right. Anybody have any questions?
Someone was saying that it's not useful with iOS. It's correct. Some of them has not access to iPhone, for instance, but people can use it with the laptop. And there are different models, and every day is more common to see more and more options. And for sure, the price will be drop during the next few years due to the interest of people.
Okay, let's maybe hear from Terry in Asunción, Paraguay. Terry, do you? What's your experience? I know you're kind of technologically advanced. What is your experience with telemedicine in Asunción, Paraguay? And do you have any devices that you might recommend?
Hey, how are you doing, guys? I have found an app for telemedicine. And what we're doing is sending like Android phone with that camera to the patient as equipment for evaluation. But people are not quite well using telemedicine here because they still like going to the clinic or to the hospital. Like there is not much COVID here, so still it is not working as we are desiring it to work, but is a definitely good option. What I was thinking that if we can improve the service with the audiological assessment, it will be great. So I'm pretty interested in the platform you're using. Great lecture, doctor.
Martin, can you unlock your? Can you hear me, Martin?
Yes.
Okay, good. I appreciate that. Hold on a second, guys. All right, listen, Nega, you're in Addis Ababa, Ethiopia. Kind of a different scenario in Ethiopia because many people do not have landlines. The majority of people use cell phones. Nega, are you doing any telemedicine whatsoever in Ethiopia? You're going to have to unmute yourself, Nega, or I'll do it for you. Hold on. Nega, so we can hear you. There you go. Hold on a second. Yeah, Nega, okay, good, there you go. Can you help us out of Ethiopia and tell us what's going on there with telemedicine?
Hello.
Yeah,
Can you hear me?
we can hear you, Nega. Okay, well, that answers telemedicine in Ethiopia. I'll tell you a few things about Ethiopia. The government shuts down the internet when it gets politically unfavorable for its political platform. And number two is they have fairly slow internet, depends on the day. So unfortunately, Nega's caught up in this situation right now. Agata, why don't you talk to us and tell us what's happening in Poland? Agata works at a large public hospital in Poland, and maybe you can help give us a little insight as to what's going on there. Agata, you're going to have to unmute.
Yes. Now we don't have a terrible situation. We already, the government want to change our policy to COVID, and we will see what will happen. I don't hear you.
Are you doing much telemedicine?
Yes, a lot of, but only in outpatient departments. I stay still at hospital, and at hospital we don't do it.
Okay, very good. Anybody else have any questions or would like to make comments as to what's going on in telemedicine? Anybody from Jamaica, India, have any comments?
Yeah, I yeah. Me Aziz have a question.
Okay, this is Aziz from, is this Aziz? Aziz.
Yeah,
Aziz
yeah,
from Somaliland.
yeah, bro.
Okay, Aziz lives in Somaliland. It's an
Yes.
area in northern Somalia that's isolated and it has a different
Yeah,
uh,
sorry for internet. Uh, what I have seen as a my experience in telemedicine is I have because of I'm only specialist in population of 2 million in different places and remote areas. So the only time that I use for follow up of my tonsillectomy patients some of the times, and I ask them to show a pictures of their oropharynx and nasopharynx, something like that. But is there any way to examine the ear that I can do, because of some of the patients live in a very far places, so ear examination is a quite difficult. So is there any way that I can use, for example, and I have seen now in digital small otoscopies, but is there any other options available, for example,
Mark,
in terms of hearing tests?
Martin, do you have any comments on that?
About equipment.
Yeah, for the
Well, I expect to see better equipment during the next few years due to the increasing popularity of the telehealth. I would say $12 for a for an endoscope is a very good price. So, in my opinion, it works. It's completely over the counter. It's not a medical device, so people can buy it over the counter. And at respect of the audiograms, I guess we will see much better equipment during the next few years. I know people in some institutions are working very hard in having equipment that can test, for instance, bone conduction, that currently we cannot do it through internet. So that's it. I would
Great.
say that the future is promising, and I would say this
Okay.
is, in my opinion, telehealth and teleotology. It will be more common after pandemic.
Great.
It's not just because the situation. Probably the quarantine time it's over, but I think we will keep on mind that telehealth can help people beyond the emergency. So I would say I support the use of telehealth as a regular basis during the next time. That's my opinion.
well, listen, feel free to use this platform to communicate to Martin. WhatsApp. Again, please no advertising of courses or anything without approval. But please, communicate with Martin. I think there's a huge amount of opportunity here for everybody. A $12 otoscope that plugs into your
Okay.
phone is fantastic. Audiometry, you can get apps online. There's free apps on the App Store and Google Play. I recommend you test them with your family and friends to feel what you're comfortable with and what works best for you and your hardware. So, Martin, really thank you for such an interesting topic today, because most of us are obsessed with patching eardrums and doing mastoidectomies, when in reality, the main goal here is to learn how to take care of the patient, especially in a remote environment, and help them get through their worries and help give them a diagnosis. So, unless there's any further questions, I'd like to thank Martin, who came live from Bogota, Colombia, to share with us. And we'll look forward to you know, you're communicating with them on the WhatsApp platform. So I appreciate everybody joining us today. Next week, just for your knowledge, I'm going to lead a session on interactive session with everybody, cameras live, microphones live, and we're going to talk about interesting cases. It's going to be an interactive program next week. All right. Looking forward to talking to you guys. Any questions, get us on WhatsApp. All right, Martin, thank you.
Thank you. Thank you, Richard. My pleasure. Thank you.
And as they say in Bogota, vaya con Dios, okay? Which means go with God. Or inshallah.
Thank you.
Inshallah for Aziz. All right, take care, guys. Bye.